All right, I think we can go ahead and get started.
You can hear me, right?
Yes, I can hear you.
Okay.
All right, so hello and welcome to CortiCare's webinar on significant changes in EEG. I'm Brad, and I'm hosting and moderating today. Your presenter is Dr. Navita Kaushal. She's been with CortiCare for almost 5 years now, but has 10 years of experience in the neurodiagnostic field, as well as 14 years of teaching experience in anatomy and physiology, and 10 years of research experience exploring the effect of sleep deprivation and hypoxia on the progression of neurodegenerative disorders. She's obtained her bachelor's, master's, and PhD, currently holds credentials in REEGT, RNCST, and NACLTM. She's a wealth of information, and we're very excited to have her here to present this webinar. So without further ado, here's Dr. Navita Kaushal.
Okay. Good afternoon, good morning. I had microphone issues, so I apologize for the delay. So let's get started. The topic for today is significant changes in EEG. So we are going to talk these changes when you have a normal EEG as well as abnormal EEG. So I have nothing to disclose. The EEG samples I have, some of it I collected from the web and some from the patients that we monitored, and all the identifiers have been eliminated. And these samples are purely for educational purpose. So Brad, if you could open the first poll, please let me know what your role is so that we understand our audience.
From the sidebar, you'll just need to click on the polls icon, and then you'll be able to select an answer. Just a couple more seconds. Okay, this is our results.
Okay, so from the poll, it seems most of you work in combinations of hooking up patient, clipping the EEGs, reviewing them, and monitoring in real time. And we have, I think, one student, so welcome to Neurodiagnostics. So this presentation is tailored for everybody, basically, but especially for people who are doing combination of all three, right? So we do have lots of people in the audience for that. So when we are talking about changes in the EEG, how are we categorizing them? What are the things that we are looking at when we talk about change in EEG? The change can be subtle or can be dramatic. It is staring right at us, right? There is change in the background, and when you do the reactivity, could be noxious stim, hyperventilation, or photic. You see changes in the background. Any medication, depth of anesthesia, depth of sedation, changes in the pattern. That's what we are seeing, right? Any changes in the frequency, any changes in the location. So pattern is present at one place and then it's not there, and then maybe it has migrated somewhere else. Or maybe it started as focal and then it becomes a generalized pattern. So all these categories have to be kept in mind when you are thinking, oh, is there going to be a change for the EEG that I'm reviewing or I'm monitoring, or when I'm hooking up a patient and I'm going to go back and look at it again. So when we talk normal EEG changes, of course, the reactivity, you are asking the patient, open, close your eyes. You're going to see some benign variants. Some of them are sharply contoured. And of course, the changes during sleep. So here with eye closure, you see alpha rhythms. That is what is a posterior dominant rhythm. So every time you do a reactivity, you do talk about if the PDR is present or absent. Always remember your PDR is alpha. Your delta, theta, and beta frequencies, they do not fall in a category of PDR. PDR is alpha rhythm, 8 to 13 hertz. So anything before or after those frequencies is the background of the patient. Of course, alpha rhythms is also background, but that is considered posterior dominant rhythm. And when you ask the patient, especially when you're running an outpatient study, you are going to encounter lots of sharply contoured waveform in the occipitals. So when the patient is awake, it's lambda, but when the patient is asleep, those are posts, and these fall under the normal category. So here is a change from patient being awake to drowsy to stage 2 sleep, stage 3 sleep, and REM sleep. We always see the eye movements, and then the frequencies change. The voltage also decreases. And then you start to see sleep architecture. You see sleep spindles, there are vertex waves forming, and of course there are posts at the occipital channels. And then as the sleep deepens, you are starting to see vertex and sleep spindles together. There are K complexes. Keep in mind, not every K complex is followed by an arousal, arousal that is clearly visible. Patient can go back to sleep even if you see K complex. Both vertex and K complexes, they are sharply contoured. K complexes are broader, and vertex waves are of lesser duration than the K complexes. You may or may not see sleep spindles after the weak vertex waves and the K complexes. All right, so the top here, the yellow EEG here is stage 2, and at the bottom is stage 3. You see stage 3 is delta sleep. The only time delta is considered healthy is when we sleep. You see delta in patients who are obtunded or who are having altered mental status. So that is a hallmark of brain pathology. But seeing delta during sleep is very much normal. And people who do not have N3 sleep, their sleep quality is bad. We always call delta sleep defines the quality of your sleep. And during stage 3, you are still seeing sleep spindles. The brain slows down up to 1.5 hertz. So you will see 1.5 hertz delta during stage 3 sleep. REM sleep. Saccadic eye movements, theta frequencies, and no EMG. The EEG looks like as if the patient is awake. So you have mixed frequencies, alpha, beta, theta. But how do you know it is REM? Of course, clinically, you can see the patient is asleep, but there is no muscle activity. All right. So here is a question for you. So go ahead and select what sharply contoured or the sharps that you see in the occipital are considered normal. We have quick response.
And I'm closing the poll in 3, 2, 1. And there's our results.
Thanks, Brad. So the correct answer is B, posts and lambda. Posts are seen during sleep and lambda is seen when the patient is awake. Now mu, when you think of mu, think of muscles. Think of the central region of the brain where the motor strip is. And when you think of RMTD, that is on the temporal, theta activity at the temporal, which is a pattern of drowsiness. So posts and lambda are the sharply contoured or the sharps seen at occipital. They are considered normal. They are the benign variants. So here is an example of interictal discharges in a patient who has occipital epilepsy. So when you are differentiating if those are epileptic sharps or if they are not, you always have to look at the feet. You have to see, is it getting, are you seeing it somewhere else, the distribution of the pattern, right? So here, if you see, the pattern is mostly in the left posterior quadrant, sorry, in the right posterior quadrant of the left, and there are abundant occipital spikes. And if you look at the field, they kind of define that, okay, they are not a benign variant. And you see patient's background is slower. Of course, anybody with epileptic discharges have on and off slower background. Let's talk about abnormal EEG now. What are the changes? How are you defining the changes when you hook up a patient in ICU, when you're reviewing that EEG? You're going to look at the continuity. How continuous the signal is. Do you have any signal attenuation? Is there any suppression of the signal? What is the morphology? Is this just barely delta theta, or are you seeing continuous or discontinuous sporadic discharges? Are there discharges with faster frequencies? Are they sharp, spike and wave? Are they triphasic morphology? The pattern that you're looking at in your abnormal EEG, is it periodic or is it rhythmic? So please be very careful when you're defining a pattern, when you are differentiating between periodicity and rhythmicity. So periodic pattern, you have interburst interval. But in the rhythmic pattern, you have a continuous waveform. There is no interburst interval between the pattern. Okay, the voltage goes up and down. It could be because of patient's clinical state. It could be because of stimulus-induced factors. And then, of course, the frequencies. The background frequency as well as the frequency of any discharges that are present in the EEG. So according to the ACNS guidelines on EEG terminology, so here are the 4 classifications when it comes to the continuity of the background. Continuous, we know that the EEG is continuous. There is no attenuation. There is no suppression. And then based on appearance of or the presence of discontinuity, the pattern can be classified as nearly continuous. That means you have only 1 to 9% of the record showing suppression. So rest, 91 to 99%, you are still seeing cortical activity. A discontinuous pattern is when you see 10 to 49%. There is mild, little bit of a change from the older terminology. So discontinuous is 10 to 49% of attenuation or suppression. So that means still more than 50% cortical activity is seen in the patient's EEG. And burst suppression is when the suppression or the attenuation is more than 50%. So anytime you are seeing a pattern with discontinuity, don't just jump into a conclusion that it is burst suppression. The duration of the discontinuity, the duration of the suppression and attenuation defines if the background is nearly continuous or discontinuous. 50% is the mark. More than 50%, you have burst suppression. Less than 50%, you may have discontinuous or nearly continuous. It is important because patterns change, right? The patterns evolve. I'm not saying the seizure kind of an evolution, but you may have somebody having discontinuous EEG and now they are becoming continuous. So in here, I'm showing you an abnormal ICU pattern, which is continuous. There is hardly any break. There are continuous discharges throughout the EEG. And then gradually you are seeing that the pattern is having less and less discharges, but it is still near continuous. Why? Because the attenuation or the suppression is less than 10%. So 1 to 9%. It means maybe 1 or 2%, 1 or 2 seconds per epoch, you are seeing the attenuation. And this clearly is burst suppression. So you count how many seconds the bursts are appearing and how many seconds you have suppression. So if your bursts are less than 50%, if your suppression is more than 50%, you're going to categorize that background as burst suppression. Okay, interburst interval matters. You just cannot, just because you are seeing bursts and you are seeing some sort of attenuation or maybe suppression, you just cannot jump to a conclusion and mark every pattern which has interburst interval as burst suppression. You have to take a look what the voltage is, the interburst activity, what the voltage of this activity is, right? So if you see about more than 10 microvolts of activity in between the bursts, that pattern is going to be defined as burst attenuation. Bursts can still be high voltage. They can be epileptic or non-epileptic, but what matters is the interburst interval, the voltage of it. So here is a question just to get that idea, carrying it forward so that we do not forget between burst suppression and burst attenuation. Okay, so it looks like we still have some doubt about how to differentiate burst suppression from burst attenuation. The voltage of the burst is going to be the same. The duration of the suppression defines the continuity. And the duration of the burst also defines the continuity. So the duration of suppression as well as the burst tells you if the pattern is continuous or discontinuous, right? Mostly it is, we have to focus on suppression. Now the voltage of interburst in activity. Okay, the voltage. If the voltage is less than 10 microvolts, it is suppressed. If it is more than 10 microvolts, it's attenuation. So basically your background, whatever the frequencies are, so I'm going to go back to show you this slide here. So we are having delta theta, some faster frequencies here, and their voltage is a little over 10 microvolts. Compared to this particular slide where the voltage is completely, the signal is completely suppressed. The voltage is maybe 1 microvolts. So the difference between burst attenuation and burst suppression is the voltage of interburst interval activity. So how would you describe burst suppression? You can mention it in two ways. One is the relative value. Okay, so you can give it as a ratio. Now we know that 50% suppression means it's the pattern is burst suppression. The other 50% are the bursts. So it can be ratio. You can say it is 50-50, 1:1. That is the ratio. You can give an absolute value too. So absolute means you take multiple epochs and you virtually count number of seconds a burst is appearing, number of second suppression is appearing. So you do it couple of times to get an idea. Okay, so the suppression is ranging from, let's say, 4 seconds to 15 seconds. The bursts are ranging from 1 to 2 seconds or 1 to 3 seconds. So you can give an absolute value of the duration of the burst as well as duration of the suppression. Other most important thing is the morphology. Are your bursts just delta theta, which seems to be very benign, right? Or do they have sharps and spikes intermixed with them? Or are they purely spike wave discharges, right? So morphology of the burst is an important component when you're describing your burst suppression pattern. Voltage of the burst, are they fluctuating? Are they remaining the same? Are they high? Usually the bursts are higher, right? And the asymmetry. Sometimes there are different things going on in both the hemispheres. One hemisphere may be sicker than the other. So is there an asymmetry, or the bursts are symmetric? Are they synchronous? If there is a change in the duration of the suppression or the morphology of the burst with stim, what are the changes you are going to see when the patient gets stimulated? And when the medications are changed, maybe the sedation is lowered. Now, what does the burst suppression looks like? So that is the time, like we get requests from the nurses, or when they put an annotation on the EEG, lowering sedation, right? So at that time, you have to be like on the edge of your seat. Okay, the patient was presented with status epilepticus, and now they're decreasing the propofol. So what's going to happen? The EEG may remain suppressed for some time, but eventually the electrical activity of the brain will kick in, right? Now, when the activity comes back, is it still epileptic, or it is slowing, or maybe the patient is going back to normal rhythms? So that is when you have to be very careful, especially when the medication is the sedation is being lowered or changed sometimes. And reverse can happen too. When they are increasing the sedation, you will be seeing less and less bursts, more and more suppression. We see lots of confusion between defining burst suppression. Let me start that. We are seeing lots and lots of confusion in describing a pattern if it is a burst or a discharge. Discharges are not bursts. The discharges, like the periodic LPDs, GPDs, BiPDs, right? They can occur with some background frequencies, and they can appear on a suppressed background too. We got to differentiate them. What is a burst? What's a discharge, right? The discharges can be consistent, they can fluctuate, they may evolve, or they may remain static. So I have 2 poll questions, one after another. You have a sample, and if you can please tell me, do you think if these are GPDs or it is a burst suppression? Okay. I think, Brad, we can go to the next
Yeah, I
poll.
closed it. Oh, okay.
So this is another example.
I'm closing the poll now.
Thank you. Okay, so this one was straightforward, right? Everybody recognized this as GPDs. Yes, they are GPDs because they're periodic and we have interburst interval between them. Now here, you have activity, you have suppression. Activity, suppression. This is not burst suppression. These are fluctuating GPDs. So we have split audience here, and that's exactly we see. Why this is not burst suppression? Of course, we have suppressed background. Why aren't we considering them as bursts? They are not bursts. They are spike and wave discharges, which are fluctuating. So if you have to give frequency of these, you are going to count how many of these are appearing in 10 seconds. And you will count at least 5-6 epochs like that, and you give an average. That, okay, so these are 0.4, 0.5, or maybe or give a range, 0.4 to 0.6 hertz GPDs of spike wave morphology. I'm not saying it. This is what the ACNS guidelines are saying. A discharge, the duration of the discharge is less than half a second. Okay, either half a second or less than half a second. So if you look at this pattern here, the spike wave discharge is less than 300 milliseconds, at the most 350, because this is a larger wave here. You can say that, okay, so it's still going 250 to 300 milliseconds, so less than half a second. So the rule of the thumb is you don't have to count the phases, you don't have to go into deeper into this. Of course, there are multiple factors here to define them. A discharge is a shorter thing. Burst is longer. Burst is longer than half a second. It has 4 phases. So any activity that you see on a suppressed background or in an attenuated background, which is less than half a second, is considered a discharge. And then you define the morphology. You talk about the location, talk about the synchrony. So going back to this particular slide here, burst suppression versus discharges on suppressed background. So discharges are not bursts. Now we know it's the duration of the activity. So you can see discharges which are occurring with background frequencies as well as with suppression. Okay, so you need to define it clearly. Now for this pattern can evolve into more discharges, right? Right now we have 0.5 hertz. It can become 1 hertz. So that is a significant change in the EEG. Okay, all right. So what are the periodic and the rhythmic patterns that we are seeing on the EEG? So according to the ACNS 2023 guidelines, there are 5 periodic discharges. You have GPDs, LPDs, BiPDs, stimulus-induced PDs, and then birds. Birds was something we were using for neonates for many, many years, but it's been introduced to adults also. So birds, the way I remember it, I think them as seizure fragments. So if I am seeing rhythmic activity in a patient, could be focal, could be generalized, that gives me an idea. That's what their seizure is going to look like. Okay. And then there are 2 categories of rhythmic activity. Rhythmic activity means a pattern is rhythmic when you do not have interburst interval, like GRDA or LRDA. In the 2021 ACNS guidelines, spike and wave, sharp and wave has its own category. Okay, we are not going to define all this. We're not going to go over this, but just so you know, when you're looking at any EEG, especially the ICU EEG, right, you are going to look at the patterns in terms of, are they periodic, are they rhythmic, or are you looking at spike and wave or sharp and wave? So most of you have hooked up patients in ICU, so please let me know what you think is the most benign pattern. Benign in the sense a pattern which will not evolve into seizures, okay? And patient may remain in that pattern, right? So what pattern do you think is the most benign pattern in ICU?
I'm going to end the poll in about 3 seconds. And it's over.
Yeah, we have quite a split audience here. I'm going to show you a picture to give you an idea. What was I talking about? So I kind of think it's a table for naughty kids, right? So on the vertical axis, you have the mortality, the percentage of mortality, and on the x-axis, you have association with seizures. Now, these are all the patterns we just talked about that you can see in EEG in ICU patient. Your GRDA is very much sitting in the corner. Like there is nobody giving it company, basically. So it has the least association with mortality, least association with seizures. So going back to this question here, what is the most benign pattern in ICU? The correct answer is GRDA. Now, those who think LRDA and birds, so here is birds, like I told you. Those are the seizure fragments. That's what the patient's seizures will look like. The rhythmic activity is going to look like that. Okay, so brief ictal rhythmic discharges. That's what birds are. Okay, LRDA and LPDs. So if you look at this, LPDs have the most association with seizures. So if you ever are monitoring or reviewing a patient who has LPDs, we are not talking generalized discharges. We are talking lateralized periodic discharges. Patient will have the seizure on the same side where those discharges are appearing. LPDs have 100% association with seizures. LRDA is right behind LPDs. LRDA has up to 70% association with seizures. Both these lateralized patterns, whether they are rhythmic or periodic, they have close to 40 to 50% association with mortality. So they have higher risk. Patients with these patterns have higher risk to have seizures than basically to die. All right, so what is associated with mortality? Bilateral independent periodic discharges. These discharges have the most correlation association with mortality. And it is seen the patients who recover, they never regain their cognitive abilities. Patients with bilateral independent discharges. GPDs have almost a similar association with mortality as well as seizures, but its correlation with seizures is significantly less than LRDA and LPDs. Okay, so your GRDA is the most benign pattern. LPDs has the most association with seizures. Patients with BiPDs, they may not recover. So when you look at discharges, you are going to describe them. They may change, right? They may change in frequency. They may appear sporadically. They may come and go. Their prevalence may be high at one point, and then the patient's state changes. They may not be as prevalent as they were before. So this picture is from the ACNS guidelines, the terminology guidelines. So always describe your periodic discharges, what their frequency is. What's their duration? Are they continuous? Are they appearing for very long time or long time? Are they very brief? Okay. Then the prevalence. Are they continuous or abundant or frequent? So all this information is necessary when you are reporting a pattern. So just to repeat, your discharges that you are seeing on EEG, they can be consistent, continuous. They can be fluctuating. They are 0.5 hertz now, but then they become 1.5 hertz. They become 0.7 hertz. Then they are becoming 2.2 hertz. So they can be fluctuating. Now they are evolving. At one time point for about 6 to 10 seconds, they are 1 hertz. Then for another 6 seconds, they are 2 hertz. Then they become 2.5 hertz. And they maintain that 2.5 hertz, right? So they are evolving. That means whatever frequency was before, they evolved into an ictal pattern. And the discharge can be static. Okay, here is another poll question. Which pattern is highly associative of seizures or status epilepticus if left untreated?
And the poll is closed.
All right. So over 50% people answered correctly. LPDs have the most association with seizures. If LPDs are left untreated, patient can get into focal status epilepticus, or the discharges can get generalized and can become GPDs, and it can be a full-on status epilepticus. Okay, SERPIDs. SERPIDs, we'll talk about it, but the physician I worked with, some of them, they are not bothered about even the stimulus induced more than 10 second of activity. So more than 10 second is basically 2.5 hertz of discharges for more than 10 second is considered an ictal event, right? It's a seizure. So they do not worry about it unless it goes as long as between 2 to 5 minutes. GPDs, they do have association with seizures, but not as high as the LPDs are. So your LPDs are highly associative. Doesn't mean that the GPDs will not become status epilepticus, but LPDs have the highest correlation. Okay, abnormal changes in background in terms of morphology, periodicity, and rhythmicity. So we just talked about it, that the GPDs or LPDs, they can evolve. The evolution can be defined in terms of morphology. Okay, so they may be blunted discharges and suddenly they become sharp or spike and wave or polyspikes. They can change their location. Their distribution can increase across the board. The prevalence may be higher. The frequency increases. And if your GPDs or LPDs are present with modifiers, it changes the dynamics of the EEG completely. So the new guidelines tell that your 1.5 hertz LPDs versus LPDs with modifiers, it has a complete different clinical meaning. So we're not going to dwell into that, but so please remember that the modifiers are important. So your modifiers are faster frequencies, sharp activity, and rhythmicity. So here are some of the examples. Here I took an EEG of a patient which shows evolution of lateralized periodic discharges. So the first glance tells me left greater than right, but they are generalized. The 50% rule applies here, so I'm going to say that left side discharges because right is lower voltage. So they are less than 1 hertz actually. So here, if you see, they are becoming closer to 1 hertz. And some faster frequencies have started to build up at the left central region. And we have still left frontal discharges are present, but if you look at it, the central and the temporal on the left side, there is semi-rhythmic activity with faster frequencies. So this pattern was marked as a subclinical event by the physician. So this is, I think, 3 or 4 slides. And then the faster frequencies are kind of becoming less and less, and you're still seeing the discharges, and the right side discharges started to appear. I'm going to go back and show it to you again because it does show a significant change in the EEG. So here, attenuated background, this is the first one, right? No, this is the first one. So attenuated delta background, you have LPDs. Why they are LPDs? Because the voltage on the right is less than 50%. So it doesn't qualify to be GPDs. Next slide. And look at the EKG too. Patient has tachycardia. The heart rate is close to 120 beats per minute. So here they are becoming faster. And in the last 2-3 seconds, you see the left central and partly temporal lobe, they are starting to show faster activities. And you have semi-rhythmic faster frequencies on the left. The discharges on the right are looking more and more attenuated than they were before. And patient is having a subclinical left-sided event. And gradually those frequencies, faster frequencies, are gradually disappearing and the discharges are reappearing. And here in the postictal, we are seeing sharps on the left. Again, left greater than right. This is still categorized as LPDs. Okay, changes in background in terms of morphology, voltage, continuity, and frequency. So here, this is about 15-20 second epoch of a patient. You see the background is theta frequencies, but there is attenuation in between. So this is discontinuous theta, or even if you want to do it like the fluctuating voltage, fluctuating frequencies in the background. So you have delta theta frequencies here. So here there are runs of discharges. You have to have 6 cycles. 6 cycles of discharges. So maybe 1 hertz for 6 seconds, or 2 hertz for 3 seconds, or 3 hertz for 2 seconds. So multiple of 6, right? Basically. So 6 cycles of discharges to mark them as periodic discharges. If they are not cycle of 6, then you are going to mention them as sharps or spikes, whatever their morphology is, runs of sharps and spikes for 3 seconds. But here, if you see, this is more than 6 seconds, so it's safe to call these discharges as GPDs, intermittent runs of GPDs lasting for 5 to 6 seconds. Okay, this is another example of a patient, a 73-year-old woman, known history of breast cancer and pulmonary embolism, as well as heart failure. So who was brought in because she was found unresponsive. So this is her day 1 EEG. In this EEG, if you see that you have attenuation of the signal, whether it is suppression, burst suppression, or it is discontinuous, it's hard to say from this particular epoch, right? And there are about 2 hertz, 1.5 to 2 hertz of discharges. And they are fluctuating. So they are 2 hertz, then they're becoming 1.5 hertz. So fluctuating discharges. Okay. So here the discharges are coming down, but if you look at it, you have discharges with faster frequencies here. Day 2, the discharges are coming down. Background is still attenuated, but you can clearly see some delta theta frequencies. And we usually see this happening in a patient who are hooked up for 2, 3, 4 days in a row. Okay, let's change gears from actual background to any change in the background due to stimulus. So if you have hooked up or reviewed EEG, have you seen any pattern that got terminated or got attenuated? I'm not asking about presence, like it appeared with stim, but it got terminated with stim, or it got attenuated with stim. For example, if somebody's having 2 hertz of GPDs, nurse comes and does the suction, and the patient is now having 0.5 hertz, right? But 2 hertz can become 3 hertz also. So if you have ever come across stimulus terminated or stimulus attenuated pattern. All right. So 60% of you have seen this pattern. It means you have seen that a pattern that was abnormal or was of higher importance, it kind of calmed down with stim. And about 25% of you have not seen it. It's not a very usual pattern, I would say. This term wasn't there. The stimulus terminated EEG pattern. It was not there in the earlier EEG terminology. In the latest one, they have included this. This is something of a newer thing. So when you are giving a stim to the patient or if the nurses are suctioning or repositioning the patient, you're going to see change in background. Okay, if there is no change, you can always mention non-reactive background, right? But now with all that maneuvering the patient, and then maybe you're using your lemon prep, you're putting the electrodes, you're readjusting the leads and all that stuff, right? And suctioning is one of the biggest stim in ICU. Some patient who has non-reactive EEG just go to the nurse and tell, hey, can you suction the patient? So that kind of irritates their trachea, and you can see reactivity actually, which you are being marking for days, non-reactive, but suddenly you have a suction thing going on and the patient will be showing reactive background. Okay, coming back to this. So when a stimulus is given to a patient, you may see the ongoing activity ceases. Okay, you may see there are changes which can both be benign as well as malignant. That means a patient who has delta theta burst suppression, suddenly they start to show GPDs or maybe birds, right? And then the background rhythms change. So the frequencies were slower, now they became faster, and the opposite of that can happen too. And if the patient is having discharges at the baseline, those discharges, they may increase, they may decrease, or they may evolve into a full-on non-clinical or sometimes myoclonic seizure, right? Okay, so now what if you are seeing the discharges, the GPDs or LPDs increasing to 2.5 hertz? Okay, let's say from 1 or 1.5 hertz, now they're 2.5 hertz. There are modifiers associated with that. If it is for less than 10 seconds, you're going to call them birds. And if it is longer than 10 seconds, it's going to be an event. So stimulus-induced event, that's what you will mention it. You will mention the morphology, you will mention the evolution. Now that may last for 10, 15 seconds, that may last for 5 seconds, or it may go on as long as more than 2 minutes, okay? So you are definitely marking it, definitely reporting it. Does it cease? Does that cease in the sense, not the seizure cease, does the pattern go away? The stimulus-induced ictal pattern, if it goes away, like I mentioned before, 2 of the physicians I worked with before, they would not treat it. They would not increase the sedation. Rather, they would tell the staff, hey, whatever you want to do, just do it once, right? The medication, the bathing, the changing of the sheets, everything you want to do, just do once so that the patient is not disturbed multiple times, okay? Now, if you are seeing the changes are 2.5 or 3 hertz going on, it's an ictal event, right? So you had 2 hertz discharges, now you have 2.5, and they did not evolve. They remained consistent at 2.5 hertz, right? This is not an event, but mark it, make sure that you inform the physician, because that is something to keep an eye on, right? Okay, so you see patient is having eye blinks. Patient may have abdominal myoclonus kind of a thing happening, like as if they're coughing, and they may have EMG with stim. Those things are not reactivity. So you cannot call them stimulus-induced changes. Those are changes in the patient's body, but there is nothing happening in the brain. So that would consider as non-reactive. So I have a picture here, I guess, yes. So this is picture of birds, brief ictal rhythmic discharges, okay? Now, if these patterns are coming along with some sort of a clinical feature, keep an eye. Patient is going to have electroclinical seizure, okay? These are not going on for longer than 10 seconds. So here you have short duration, you have the discharges, the LPDs, and then you have 2 seconds and about 5 seconds of birds here. So I'm not going to dwell a big time into birds, but here's a question for you. Which of the following statement about birds is correct? I mean, those who have worked with neonates, you might have marked hundreds and thousands of birds, right? But seeing them in adults, they were there. They were always there. We weren't marking them as birds. We used to mark it as rhythmic activity lasting for 2-3 seconds. All right. So about 70% people think that everything is correct from A, B, C. Those are the correct answers. So anytime you have a rhythmic activity lasting less than 10 seconds, of course, neonates have it extensively. And when you see birds happening in certain particular channels, that's where you're going to have the patient will be seizing in those channels only. If it is generalized, that's a different story. But if you're seeing just 1 or 2 channels having birds, yes, that's where the seizure is going to happen down the lane if the patient is not getting enough medication. So those who got all are correct. Yes, they are correct. Okay, so here are some examples of stimulus-induced changes. Here you see attenuated delta. And then with the stim, the delta became, for 2 seconds, we had faster frequencies, but then from 1.5 hertz, the delta is about 2.5 hertz. So this is stimulus-induced increase in delta frequency. And then not patient, so we're still talking patient number 1. So in the same patient, we are seeing poorly formed right-sided discharges with stim. Do they go away? Yes. If they remain, just watch them for a couple of minutes, make sure they don't evolve, make sure there are no significant changes in the frequency and the morphology and the rhythmicity of these, periodicity of these discharges. Okay. And I showed this slide earlier. So here, this patient is having stimulus-induced runs of generalized discharges. So these are GPDs since they are six cycles. Patient number 2, presented after cardiac arrest. Patient has diffuse alpha. That is something we usually see in patients. So diffuse alpha is like alpha coma, right? That's what we would call it. So it was a surprising patient, basically. The pattern surprised all of us. So we were like, okay, patient is in alpha coma. So patient was, a stim was given. There is increase in alpha activity. Then, of course, there is EMG too, right? But still, it remained alpha. So we are saying mildly reactive. Some are saying it's not reactive because the frequencies are still in alpha range. And then boom, suddenly the same patient developed myoclonus. Now, if you look at the EEG clearly, the alpha disappeared, but we are not seeing any epileptiform discharges correlating with that myoclonus activity. So what happened there? That means patient's cortex is already sick, and all the inhibitory effect that the cortex is providing is giving to the signal, which is coming from the brainstem, right? It's a cardiac arrest. So cortex is the first one that gets affected because of the blood supply, right? So cortex is sick. Now the signals that are coming from brainstem, they are not getting inhibited. They are not getting controlled by the cortex, and you will see myoclonus. Okay, this is not cortical myoclonus because we are not seeing any epileptiform discharges with it. Okay, myoclonus goes away, so does alpha. No, we are not seeing diffuse alpha in this patient. The patient is showing bifrontal discharges. So that was quite a change. We were all thinking, oh my God, this patient is in alpha coma, will stay in alpha coma, it will be an easy thing. But here, there is a significant pattern change in a couple of minutes in this patient. All right, patient number 3. So here, if you look at this, in the first half of the epoch, there are slower periodic discharges, okay, on the left side. So maybe about 1 hertz, 1.5, no, less than 1 hertz, I would call it. And when the stim is given, the discharges started to appear on the right side too, but they are not synchronizing. So we have stimulus-induced bilateral periodic discharges. And when after 1 minute of stim, EEG is completely different. Okay, so now the patient is having bursts of epileptic activity, but that is asynchronous. If you look very clearly, you remember we had left-sided discharges, right? To begin with, LPDs. Now, after the stim is gone, right? The patient has gradually recovering from the stim. The right side is showing mixed frequencies, discontinuous mixed frequencies, or maybe you can call it burst suppression because these are asymmetric bursts here, right? There is no epileptic activity on the right side. Left side bursts are with interictal discharges. So it's still a carrying over effect from the baseline of the patient. So after 1 minute of stim, there are asymmetric bursts on a suppressed background, left-sided burst intermixed with interictal discharges. So if this patient got a cease, they're going to cease on the left side, basically. But again, we had bilateral independent periodic discharges. So patient may have two different kinds of seizures. Okay, so quickly, transition into seizure. So you hook up a patient, everything looks good, and then gradually you cease, patient is seizing. So transition into seizure, it can be it is not always abrupt. That's what I wanted to say. It can be subtle because patient who is seizing today had changes happening in their brain, in their body, couple of days earlier, okay? Quantitative, couple of days or hours earlier. Quantitative EEG showed that about 2 to 7 hours before the seizure onset, there were some changes. Okay, patient's mood will change. They'll be more irritable. They may complain headache, nausea, and of course, intracranial EEG shows an earlier onset of ictal activity than the scalp EEG. So the ictal phases, you always have to keep in mind. You're not just describing the seizure. What's happening in the pre-ictal phase? The clinical changes as well as the EEG changes, right? During the seizure. Then after the seizure stops, then the post-ictal phase. What is the clinical semiology? It may be different. It usually is different before, during, and after the seizure. So here are some of the EEG changes that you would see, right? Patient has maybe normal PDR or maybe slower background. During the pre-ictal state, there are changes in the morphology and the frequency. And then we see a buildup. Buildup is increase in frequencies of whatever frequency, whatever pattern you were seeing. Could be discharges, could be delta, theta, alpha frequencies. And then we have evolution of those. So some people stop at buildup and there is no evolution. But many patients, you will see evolution of those frequencies into rhythmic activity. And it could be focal, it could be generalized. So once the seizure is over, there is attenuation of the signal. Patient's clinical activity kind of slows down too. So that is your post-ictal phase. Sorry, next one. Okay, I have a few examples here to show you onset of seizure. Patient is having alpha beta frequencies and suddenly there are blunted discharges. And there is evolution of the frequencies and patient had predominantly left-sided seizure. And the seizure stops, patient goes back to the last 3 seconds, you can see going back to their original background. So here the post-ictal phase was very short. Due to HIPAA reasons, we cannot show you the videos of the patients. Okay, this is another example. Patient had continuous fluctuating discharges and all of a sudden the left posterior quadrant started to have beta frequencies. The periodic discharges sustained, but the posterior quadrant, the left posterior quadrant ceased away. And then when the seizure stopped, you have this 2 seconds of signal attenuation. We did not have this 2 seconds of suppression, not attenuation. 2 seconds We did not have it here. Okay. So here, and the seizure stopped, the patient continued to have their fluctuating discharges. This is a hallmark, right? Generalized tonic-clonic seizure. This is an abrupt onset. The new terminology talks about gradual onset and abrupt onset. So here, if you see, just for a second, there were left-sided sharps at the temporals. Patient had alpha rhythms, and abruptly the seizure started. Patient is having full-on convulsions here. Coming down, and in the last 4 seconds, we had seen that the patient was making this gruntal sounds from the throat, so that is the postictal phase. And this here is postictal attenuation. The last component of today's presentation. So it's not always normal to abnormal or abnormal getting worse, right? So sometimes you will see changes in the EEG. The pattern is abnormal and now it is becoming normal, right? So that I feel is very rewarding actually. So here I have, this is from an article, 67-year-old patient, I'm not gonna read it, presented because was found dead. I'm so sorry, was found down, confused, incontinent of urine. Patient has history of poorly controlled diabetes, okay? Hypertension is managed, but the diabetes is poorly controlled. Patient was admitted, CT, MRI is all normal. After 8 hours, patient is still having decreased level of consciousness and they are non-responsive to the noxious tip. So they intubated the patient to secure airways. Patient was hooked up to EEG and there is no sedation. They were intubated. Here, if you look at it, patient is having discharges, GPDs, okay? And so pupil is fixed at 2 millimeter. So if you remember the history, patient had uncontrolled diabetes. So this is a case of what you call diabetic ketoacidosis, okay? And then day 2, patient is started to have, once the blood sugars are coming back to normal, all the toxins, metabolites are getting cleared from the body. Patient is still having blunted discharges, delta theta background, and they are returning to theta rhythms. So that can happen too. The EEG can change from abnormal to normal also. Another thing to keep in mind when you're looking at changes in the EEG in the background, the medication, any change in sedation. Due to sedation, if the patterns are changing, the beta frequencies are increasing. If the background is slowing, is the voltage decreasing? Patient seizure threshold also changes with the medication change. And change in continuity. So pattern can be any degree of continuity, a discontinuity, and then it significantly changes from continuous to burst suppression or from burst suppression to continuous. Not gonna go over this. I have gone above the time today, and I apologize for starting late. Are there any questions?
There are a couple in the Q&A section, Navita.
In the Q&A section, I'm not seeing that. Where do I see settings? Attendees, chat, volt.
Yeah, under chat, there's a separate tab at the top.
Oh, okay. Okay. So usually to capture such subtle changes, what is the sampling rate required? In case of so the sampling rate, all the machines are set to 500 something, right? I cannot recollect. 500 is the sampling rate. That's what all the softwares are built in, unless you want to change it. So subtle changes are clearly visible. You can always change the frequency. So you can always change the voltage, and you can change the epoch also to get to see those changes. And of course, Montage is a very important thing, what you are looking for. Are you looking for amplitude change? Are you looking for the distribution of the patterns and all that stuff? Sarah is asking, what's your dog's name? His name is Spartacus. He's still snoring beside me here. Alrighty, the other question is, in SERPIDs, the decreased voltage or frequency is considered as abnormal. In SERPIDs, the decreased voltage so if the voltage and the frequencies have decreased compared to the baseline, it depends. It depends how long that change is remaining. Any change that happens because of stim shows that the EEG is reactive. That is much better than having no reactivity at all. So you cannot categorize decrease in voltage and frequency as abnormal. Patient will have maybe for a minute or 2 minutes, sometimes up to 5 minutes, they may have this attenuation of the signal. So that means brain is sort of recovering from whatever stim was given to it, right? It's not just the body, it's the brain. And then they go back, the brain can go back, patients can go back to their original baseline. So you cannot call it as abnormal. Yes, if the patient is having stimulus-induced seizures or stimulus-induced ictal interictal pattern, which is staying for 5 minutes, that requires clinical intervention. Okay, so how long we suggest to give stimulus, and we want to repeat the stimulus to confirm it again. So if you have given stim once and you have seen the change in EEG, there is no reason to do it within a short period of time. Most of the labs, the rule is to do the reactivity once in 24 hours. Unless the patient's clinical state changes, patient is more obtunded, then they can go back and do it every 6 to 12 hours. But the ideal thing is 24 hours. Once in 24 hours, whether it is your EMU or ICU patient, the reactivity is done by the EEG staff every 24 hours. Please confirm at what age do we see PDR? 8 Hertz at 8 years. It could be 9 years, but the patient, by the time a kid is 8 to 9 years, they should be showing 8 Hertz frequencies, 8 Hertz of rhythms at the posterior channels. I saw something in chat too. Okay. What did you say the voltage difference should be to call discharges that are seen diffusely but more attenuated in one hemisphere, generalized versus lateralized? The rule is 50% of the voltage. If the other side is less than 50%, if the voltage is less than 50% on one side, then you were going to call them LPDs. You can still mention them bilateral asymmetric LPDs. So if you are seeing, let's say, maybe 250 microvolts on the left and 100 microvolts on the right side, and when you're describing them, you can mention bilateral asymmetric left-sided LPDs. So that gives an idea to the reader that, of course, there are some discharges. There are discharges present on the other hemisphere, but the predominance is the left. That's why we are calling them LPDs. Okay. Did I miss any questions? Chat. Okay. Kathleen knows my dog's name. Thanks, Kathleen. Okay, so ACNS mentioned depends upon rate and type of stim. Balaji, I'm not sure what your question is, but I'm not sure rate and type of stim. If you can clarify, please, I can answer.
That was based on the earlier question in the Q&A. Okay. Like how long do we suggest to give stimulus and repeat stimulus?
Okay. I do not recollect what ACNS is saying, how long the STIM is given. And again, we apologize for the delayed start today. Okay, I do not see any other questions.
I haven't seen any either.
Okay. I can wind up.
All right. All right. Well, thank you everyone for coming. You'll all receive an email shortly after this with the link to the replay and to the post-webinar survey. But besides that, thank you for coming.
Thank you, everyone. Have a good day.